Hello, good afternoon. This is Carmen Rosa from NIDA CCTN office. Welcome to our seminar series. This afternoon we have Dr. Jonathan Chen from Stanford. Dr. Chen has a PhD in computer science and also an MD from the University of California. He works at the Stanford Health Policy VA Medical Informatics Fellow and also at the Stanford Department of Medicine. His work is currently focused on data mining electronic medical records, and he is a young fellow that seems to have lots of enthusiasm in this area, and he's going to be presenting from his current work published in a JAMA Internal Medicine paper, and the title of his talk is Opioid Prescribing Distribution, What is Not Just a Few Bad Apples. So with that, I would like to ask Dr. Chen to start his presentation. Just want to remind everyone that we will have his presentation and then we will have time for questions and answers, and that we hope to be able to archive this presentation in our dissemination library in the future. Thank you all, and Dr. Chen, you can start.
Training, just in practice, I really kind of detected an insidiously pervasive problem that I felt wasn't getting very good attention, which is kind of opioid prescribing and all the potential dangers that can cause in kind of unclear and distant ways. So I ended up getting involved in a project here with some collaborators that ended up giving us some interesting findings that developed from there. So I'm going to go ahead and proceed with the presentation section. Just confirming, am I being heard right now?
Yes, you are. Thank you.
Okay, very good. So just to set up a little background and motivation, I suspect most of the people on this call will be on the same page, but just to make sure, currently the CDC has already recognized a public health epidemic of drug overdose, deaths in particular. Right now, it's the leading cause of accidental deaths, I think even outpacing motor vehicle accidents at this point. What I thought was even more compelling about that is that it's predominantly actually prescription opioids that drive most of those overdoses, exceeding both cocaine and heroin overdose deaths combined. And as a doctor, I found that very kind of shocking and concerning that, well, where do those come from? Those are prescriptions that a doctor wrote. And perhaps this isn't too surprising when you consider that the overall volume of prescription opioids that we're giving out has increased over tenfold over the past decade, largely due to kind of a cultural shift in what I think is appropriate. In my med school, we emphasize that, pain is the fifth vital sign and it should not be ignored, and if we have a way to treat it, we should be doing so, but perhaps not realizing the potential secondary consequences of that. So a lot more we can review there, but just given that element alone, very broadly, what my question was coming into this study that I'm going to present today was just, who is it? Who is prescribing all these opioids? So kind of looking deeper into that, well, if you look at articles from the New England Journal to JAMA to Annals of Internal Medicine to the popular press, they often like to describe these corrupt pill mills and bogus pain clinics, these places where doctors are basically just handing out prescriptions for opioids pretty much for a cash basis for profit in apparent irresponsible ways. To find a quantitative reference point, though, one of my collaborators pointed me to the California's Workers' Compensation Study just recently, where they very provocatively pointed out that just 10% of their prescribers were responsible for 80% of the opioids being prescribed, which, looking at that, it makes you think, well, geez, who are these 10%? What are they doing? And is there something strange going on in that behavior? And the particular thing that I thought was interesting about this element is that, strangely, it's kind of reassuring. When you see that there's if there's a corrupt pill mill or a bogus pain clinic, it makes you, aha, we kind of found the bad guy. There's a villain. Let's go find them, have the DEA shut them down and arrest them, and then the quote-unquote the problem is solved. But trying to dig deeper then, what I'm trying to find out is really on a broader national scale, is that really true? Is it really just a few outliers who are the source of most of the prescriptions? Because if that's the case, what that really is trying to imply is that don't worry, it's just these few outliers, these extreme prescribers. The rest of us in general use are probably fine and are not really part of the main problem. So how can we try to figure that out? What I did was I went ahead to, just recently, it became possible to study this more conveniently because Medicare just released a large data set covering every single named prescriber in the nation who prescribes drugs to a Medicare patient through the Part D system. So that covers over 55 million Americans who are 65 or have a certain disability, and about 2/3 of them would be in the Part D prescription. So I'll show you an example of this data on the next slide, but what it has is for over 800,000 named prescribers at the individual level of their national provider ID, tells you exactly what drugs they prescribe and in what quantity and at what cost. So it represents over 1 billion medication claims, although I'll be looking more specifically of interest at basically opioids, Schedule II opioids, and I did this both with and without counting hydrocodone products because their status kind of changed, although ultimately the results were pretty similar in both cases. So just to give you a flavor of what this raw data looks like, so I just loaded this large file into a large database and over a couple million different records, and what it tells you is the individual, this is the ID of an individually named doctor, and you can look up exactly who this is, what city and state they practice in, what specialty they're in, and exactly what drug they prescribe, and how many claims and what cost that is. So one very simple thing I did first, which is what it seemed like a lot of people actually picked up on, was just a simple breakdown by specialty. You know, who are the main specialties that are prescribing Schedule II opioids? And what the curves in red are showing us is on the average prescription per provider. So it makes sense that people like interventional pain management or pain management prescribe the most opioids per provider available in the system. But, you know, there's probably 70 times as many family medicine doctors as there are pain specialists. So in the blue curve, you know, if you just look at just overall volumes, overall quantity of opioids that are out prescribed on the street, basically, who is it coming from? It's not specialists. It's basically their general medicine practitioners, family medicine, internal medicine, even nurse practitioners and physician assistants. Even though on a per provider basis they don't prescribe as much, there's just so many more of us that most of the opioids, that's actually where it's coming from. This really represents the main kind of result of the study that I want to hone in on. And what this is showing us here is a breakdown based on the top most prolific prescribers, how much of the prescriptions are coming from them. So for example, if you look at the top 10%, if you look at the red curve, that is that California's workers' compensation data, like that kind of starting point I was looking at. So they found that the top 10% of their doctors were responsible for 79% of their opioid prescriptions. And when I went into this study, what I actually thought I was going to do, I thought I was basically just going to reproduce this finding on a national scale and show, wow, look at this extreme skewing in the prescribing distribution. When I actually did the study, though, what instead I found was the black curve. So what that's showing is for the Medicare data, the top 10% of opioid prescribers in the Medicare data are responsible for 57% of the prescriptions. Now that is still skewed, right? That's still a concentration, but it's any population distribution is going to have this. If you're familiar with power laws and the Pareto principle, it's basically the 80-20 rule, right? You know, 80% of the wealth in the nation is controlled by 20% of the population. So that phenomena basically reoccurs in every social phenomena. The question is more how extreme that skewing is. And if we look at a reference point, the blue curve, so I just compared to, for the Medicare data, let's just look at any drug for any reason, including just a statin, a PPI, a blood pressure medicine, any of those. There, the top 10% of prescribers are responsible for 63% of the prescriptions. So what that is telling me is, although there is skew, the opioid prescription claims are not any more skewed than any other drug that you would expect, which kind of undercuts the imagery or the narrative of it really just being a few extreme pill mills basically responsible for most of the behavior. I just did one quick check to make sure maybe there's just some extreme regional variation, and that's why things are happening differently. I actually didn't really find that. There's a little bit more concentration of opioid prescribing a little bit in the South and in some of the states you see in the West. But in terms of that skewing of the prescribing habits, how much does the top 10% of prescribers responsible for? It's basically anywhere from 56 to 57% any state you look in the nation. I thought maybe it would just be Florida, where a lot of the press has been about where pill mill behavior has been, but that really wasn't the case by the time we analyzed this data from 2013. Just to reference some limitations of the underlying data set, but also thinking about the benefits and trade-offs we have in terms of what we can interpret from it. So, of course, it is a subpopulation of the entire nation, but actually an important one that kind of gives us a lot of clues into the broader patterns of care. What powerful things it does have is that it has the data at the individual prescriber level. You can identify doctors by name and see exactly what they're prescribing. And if anything, prior studies have actually shown that in the Medicare population, the prevalence and the growing prevalence of opioid use disorders is actually rising and greater here than even in commercial populations. The other obvious source to try to study this kind of phenomena would be to look at commercial claims databases. The challenge there, for one thing, there's not as much prevalence of the problem, and also it doesn't represent a good full population either. You're going to be missing uninsured people, and then when you have insurance churn, you'll also miss out. The nice thing about Medicare is it's a comprehensive coverage. Anyone who starts to fit their criteria, it's not like they're going to lose their insurance or they're going to switch carriers. You pretty much know their full behavior across the spectrum. So it's just like that. So with those caveats in mind, the broader, what do I kind of take away from the study so far, and the broad, I think, kind of policy implications here is, assuming you even agree that opiate prescribing, there are problems in how widespread it's become. It's not enough, I don't believe, to just go after a handful of pill mills or extreme providers. That may be part of it, but really it looks like this is a much broader-based, insidiously pervasive problem. And if we're going to do anything about it, we have to figure out how to address the prescribing habits of a broad swath of prescribers, including many general practitioners. Not that they're intentionally doing anything wrong, but that's just kind of where the phenomena has emerged in practice. This actually really got a lot of interest from the popular media as well. Here's a few different sources that ended up citing the article and called me for some quotes on it. It's kind of interesting that the kind of things they latched onto were not necessarily what I thought I intended to. A lot of them painted as a picture as like, oh my God, family doctors are the ones causing the opioid problems. Like, I'm not sure, as I said, that's not really the conclusion I'm trying to make, although a lot of them tended to fixate on that. It's not that they're at fault, it's more that it's just this has become such a pervasive cultural shift in the way medicine is practiced that it's become so pervasive in the fabric of our practice and requires more attention in that setting. So that kind of sums up the core pieces of results that I want to share from the paper that came in JAMA Internal Medicine. Since we're here, I want to also share with you some additional unpublished work that's pending review that also I gathered from this data set, and also some other approaches to studying the phenomena that I think are possible now that we have different electronic data sources. So one of the other things me and a collaborator were trying to look at was the use of medication-assisted therapy and opioid substitution therapy. So, opioids, those are things like your morphines, your oxycodones, your Vicodin, your Percocet. If someone does unfortunately develop dependence, if not a straight-up addiction problem, it can be very difficult for them to stop because they'll have very predictable severe withdrawal symptoms. In that case, it turns out one of the most actually effective evidence-based therapies for people in those settings is substitution therapy. So you give them something like methadone or Suboxone, a very kind of slow-acting opioid. Essentially, it works on the same receptors in your brain, and you kind of slowly taper them off. And the prior studies show that this can do everything from reducing mortality, diversion to other drug use, crime, and even HIV and hepatitis infections, just because it gives people a recourse to temper their symptoms that they're trying to taper off. So another relatively simple question we're trying to answer, but with this data set, is well, how much is this medication or these therapies even actually utilized? And so there we took a look overall, as our reference point, 380,000 doctors prescribe opioids in the Medicare data set, yet only 6,700 of them ever prescribe Suboxone, which is the only medication-assisted therapy that Medicare will cover. It does not cover methadone for the treatment of addiction, so this is kind of the only relevant one for the purposes of this study. And as an additional reference point, other studies have shown that at least probably 330,000 people within the Medicare population would be diagnosed with an opioid use disorder. Over 220,000 of those are even hospitalized for it every year. And yet, based on our data, we would estimate that only about 81,000 such patients are actually getting this kind of treatment, which is, as far as we know, one of the most effective ones available. Another oddity we found is when we check for geographic variation, it turns out there's extreme disproportionate use of who is using the medication-assisted therapy. If you look at claims ratio, basically the number of claims for the drug, in this case Suboxone, versus the claims for any drug, it's the New England states, basically. There's 6 of them that each one of them, their rate of use is 300 times the national average, and it all seems to be concentrated just in that locale. So clearly there's variation as well in terms of how people have accepted or not accepted these kinds of treatments. A breakdown by specialty similar to before. The red curves are essentially the same information I showed you before, the average numbers of prescriptions for opioids per specialty, where you'll see, for example, people who probably know how to use opioids best are the pain specialists. They prescribe a good 1,000 prescriptions every year, but they prescribe less than 5 uses of buprenorphine and naloxone per year. The specialist who uses this type of therapy the most would be addiction medicine, almost as much as the opioids. But based on the way this data is categorized, there's only 100 such addiction medicine specialists categorized in the entire nation. So clearly that's not going to be enough to keep up with the potential demands for the therapy. And again, just a perspective of how easy it is for us to prescribe opioids, and yet how apparently reluctant one way or another people are willing to use these other kinds of therapies. For every 40 family medicine doctors that prescribe an opioid, there's only 1 who would ever prescribe Suboxone based on this data source. So unpublished work that's pending review right now, but I think there's more that points to. A lot of, again, other popular press interest that, this isn't just really a research problem anymore. It's really recognized as a public health issue that's gaining more and more attention, both at the research as well as national policy levels, and in the popular media. Probably one of the most, arguably controversial things lately, the CDC released their guidelines for chronic pain in non-cancer patients and the use of opioids in them, which has stirred up a lot of discussion, and some of which is referenced here as well, cited our prior work. And I guess what's interesting there, when I submitted that JAMA IM paper back then, one of the reviewers' comments when I said, we need to find a way to make opioid prescribing more responsible or safer, and he really pressed me saying, well, what do you mean by safer opioid prescribing? Who's to say these guidelines or protocols, interventions actually will make it safer? His argument was that the medications are just fundamentally potent and dangerous medications or drugs, and there might not be a really safe way to use them, and that doesn't mean we can't use them, but we just have to just accept that that's what the possibilities are. So challenging questions to answer there, even as in some sense, doctors are feeling like these guidelines are being pushed down from the top down, and are potentially imposing on their practices, and how much of that has a good evidence base versus not is challenging, because it's very difficult to study this. I don't have all the answers to study that, but I think some potential, and some of the other areas of research that I'm very interested in, is using things like electronic medical records to enable larger scale studies that would be very expensive or impractical to do in other ways. So this is from a small pilot study, just to give a flavor of how some of that might work. Pretty preliminary at this point, but I think it's interesting for discussion, just from even the process point of view. So at Stanford, 2 years ago, we introduced opioid prescribing guidelines into our clinics. Before the official CDC ones came out, just other groups had to put them together. So a working group at Stanford put it together because they were concerned about this issue. Outlined here are just some of the main tenets in those guidelines that they distributed to the primary care clinics at Stanford. Excuse me. One of my colleagues asked me, he wanted me to get involved because he knew I could help with the research component to evaluate whether this intervention was actually making any kind of difference. And the conventional approach to doing such a thing would be, maybe you'd set up a study registry, you would hire a research coordinator to organize the information, or actually what he wanted me to do was to just start manually chart reviewing hundreds of patient records to try to review the differences. And while that seems like a simple and natural thing to do, I also that's not a scalable approach to addressing a larger scale problem. Can we find another way to get at a good data source at scale? So in this case, what I did was I encouraged, based on my prior experience doing EMR data mining, I said, let's just go to electronic medical record and let's just download the key pieces of clinical information about these patients before and after the intervention, and that will enable us to learn a lot much more rapidly from the process. All right, so pretty preliminary at this point, but I'll just show you some of the things we put together so far. This is just the basic demographics of anybody who we counted as a chronic opioid user within the Stanford primary care clinic. So that's anyone who got 3 or more prescriptions during a 6-month period before or after the educational intervention. So before and after, pretty stable in terms of their baseline demographics. Some of the same common and most prevalent diagnoses, although, as you might expect, things like depression, low back pain, chronic use, and tobacco use disorder are probably more prevalent in this population than the general population. Right. And then to actually evaluate what happened before and after the intervention, so we narrowed it down to about 100 patients from before and 100 patients after who were on a chronic opioids before and after, looked at that subgroup, and just kind of evaluate, did the guidelines even change behavior amongst physicians and patients? Some of the things that we could easily extract from there, it looks like the rate of using random urine drug toxicology screens, which is used to detect making sure people aren't using other drugs of abuse and that they're actually having opioids in their system and they're not just diverting it for sale, for example. The rate of that did increase significantly, although notably, even afterwards, the rate of usage is really quite low. Doctors still are not doing that in a very reliable way. And then the rates of things like referrals to specialists, pain clinics, psychiatry actually still remain low in both cases. The actual patient behavior of attending some of those referral clinics, showing up in emergency rooms and asking for ER prescriptions or getting more prescriptions from the clinic did not seem to significantly change in either case. Although a relatively small rate overall, but statistically significant, that the overall number of opioids prescribed in the clinic overall did reduce over that time frame, just suggesting a more general awareness and being cognizant of the potential uses of that. All right. So lots more that could be done and evaluated here, but here I think the more interesting thing is just the process of, if you want to study something at scale, basically just go to the electronic medical record. That data source is already being generated, and there's a lot more kind of larger scale studies you can do. It's kind of this disruptive technology to do clinical trial studies without having to rebuild all the infrastructure. So imagine if you could redo the study again at scale, do it prospectively randomized, but rather than having to build a registry and a research coordinator setup, if you could use the existing EMR infrastructure to study that information. I'm going to close out with just one more piece that I have been working on. I tell my friends, it's a little bit strange. I never had any intention of being an opioid researcher, but it seems to be something that keeps reoccurring because it's just an important topic as I've been developing my work. So at the end of this month, I have a perspective piece coming out in JAMA, basically talking about my experience as a trainee, which is why I got interested in the subject, and how I felt that people weren't talking about this insidiously pervasive problem, and I really felt a real lack of structured and consistent guidance and training from physician educators, basically. Most of them just want to avoid this problem and not talk about it. And why is that? One of the reviewers I encountered before said, well, sure, training for opioids, that's something that we need more of, but there's a lot of things that our trainees aren't getting enough of. Why is this anything more important than anything else? Well, a couple of points I try to argue is that, based on another reference, addiction affects more Americans than heart disease or cancer or diabetes, but I still expect all my interns to have a principled approach to prescribing insulin to diabetics. They're not going to be endocrinologists, but that's just such a pervasive medical problem. I expect that to be a fundamental part of their skill set. And in the same way, I feel like we should be moving towards the same perspective for opioid prescriptions. And while there are many topics that compete for our education, well, if we don't know how to treat heart disease that well, that's a shame, and we're a missed opportunity of doing good for our patients. But I try to also make the argument that an inadequately trained medical community will not only not help, but they're going to routinely contribute to, if not overtly cause, these medication misuse problems, something that I feel very afraid of basically from my own training experience, that how many times did I contribute to that without even realizing it until I started to pay more attention to it. With that, I'm going to close down and just acknowledge my different co-authors on the work. The NIH Big Data to Knowledge K1 Career Development Award, which I just started on to help me in my work towards data mining electronic medical records for decision support content. The VA Medical Informatics Fellowship gave me a home for starting up a research platform in the prior couple of years, and then the Stanford Data Sources, who helped get some of that work off the ground. With that, I would most like to thank all of you for your attention today, and I'm glad to open it up for any questions or comments at this point.
Just a note, if you'd like to ask a question, you can dial *6 to unmute your line.
Hello, can you hear me?
Yes, this is Jonathan.
Yes, we can.
Oh, hi, this is Carmen. I thank you for your talk. It's very important, the part that you said at the end about training, that you expect all your residents to know about addiction and to treat them to know about addiction the same way they can treat a diabetic people. So how many people like you are out there that have the same thinking? Because you said in your other slide that there's not many.
I don't know if I have national scale data to support that claim, but my instinct and my anecdotal experience of looking at my peers is that there's very few. The instinct from, and I'm even thinking from the physicians above me basically, and you'll see this when this perspective piece comes out. That's a lot of what I commented on. Most of them wouldn't even prescribe consistent guidance, if any guidance at all. Most of them just don't want to talk about the issue because it is a difficult and challenging one to deal with. In fact, they'd rather just throw the resident or intern out in front of them and kind of shield them from the problem, so to speak. Which, frankly, I felt, and why I felt the need to write this perspective, that doesn't help me when I was a trainee, and it certainly doesn't help the patient in that way. And so I think there is a major gap there. And in fact, ultimately, the main tagline of this piece that's coming out was, it is challenging to face that. It's a scary and it's sometimes an emotionally draining problem to really do this well, and it just takes more time as a physician to do it well. It's much easier to just write a prescription and walk away. But this patient that you least want to see is actually probably the one who needs you the most, and that's actually something a medical school attending once taught me in a broader context, and that kind of really stuck with me in this setting.
Sorry. Yes, I did, but they said muted. Hello?
Hi, Betty. You've been unmuted. We can hear you now.
Oh, okay. That's because I came to Carmen's room. Okay, thank you. All right. I just want to say a few things. Jonathan, this is a very, very interesting and pertinent seminar, and I am the director for the NIDA Clinical Trials Network, and our network currently has put these, the MAT, how to expand the capacity, because I look at your data, there seems to be such a small number of physicians who are dealing with this or using prescription of MAT and largely the buprenorphine. And so this is a very timely and a very exciting data
Many of the data we sort of knowing it, but you collect them all, put them together. It's very impressive. We appreciate this presentation. I see your collaborators. There is Keith Humphrey listed there. Do you work closely with Keith, or?
He has. So, during my fellowship, I was technically a part of the VA in the prior couple of years, and he's obviously heavily involved there and the national policy level. So I kind of connected with him and Anna Lemke, who's another addiction medicine specialist at Stanford, and we, he was the one who helped, spark that idea. We were trying to brainstorm. I had this data set. I know there's important questions to answer here, and he helped spark that idea of that California workers' compensation study, and then we were able to run from there. And he's obviously been a great collaborator and a great mentor.
Okay, fantastic, because we really like to include scientists with your background into our research arena, especially at NIDA. These days, the big healthcare data can play such a significant role, and you are really one pioneer expert in this area. We would like to hopefully to engage you in our future dialogue conversation, and we like to thank you for doing this for us, and hope to continue our dialogue with you. And this is really wonderful and very timely, very pertinent to our pursuing right now. We are currently working on a research proposal to expand the using of Suboxone in primary care, and we are very much impressed the way you parallel the prescription behavior, and suggesting that if you look at the prescription for diabetes, prescribing insulin for diabetes, and that'll be very, very interesting, and it really is what we are pursuing right now. Thank you very much, and we hope to hear from you more in the future. I don't know if you ever heard of the CPDD meeting, College of Problem with Drug Dependence. And if you're going, this year is in Palm Springs. And if you're going, hope to have a time to meet you face-to-face. But if not, we like to invite you in the future to participate in our research.
Very good. Appreciate it. Yes, I think there's a lot of opportunities here, and trying to find the people who have the interest in this subject and the the skills to bring these kinds of things together. I think could be even more powerful. And like I was saying, it's strange. I never intended to be a quote unquote an opioid researcher. It was just I've noticed it was an important problem and wanted to contribute to it. And clearly, as you say, it's a very timely topic right now. And I will look into
I'm sorry. Go ahead.
I was going to say, and I will look into the CPDD meeting. I'm actually from Southern California myself, so let me find out more about that.
Sure. And also I'd like to tell you that our network has a task force. It's called the Healthcare Big Data Task Force. And what you've been doing is what we were trying to do. And so that'll be very much interested to our group. And if you be interested, we can loop you into our group, and so you can start helping us. We do have contract to support consultant at this point, and we will contact you. All right. Thank you so much.
Thank you.
Any other questions? So I have just a process question. How long it takes you to do this projects? I don't know. You said at the beginning. I missed it. Sorry about that.
Sure, not at all. It's kind of strange in the sense that I was talking to other people that the complexity or the difficulty of the process does not correlate with how important it is in some sense. So, most of the time we spent, like with Keith Humphreys and Anna Lemke and Nigam Shah, who I work with, was just brainstorming the idea of, like, what is the question that's worth answering? And once I had that California Workers' Compensation study, well, this was a free data set available, download that, load it into a SQL database. I think between, the idea to do it and then having the draft of the results, it was like 2 weeks or something. It was really more just having the right idea and the right question to ask and the source to get it. I'm specifically not doing, although I've done, multivariate analysis and Bayesian inferences using my informatics work, here it wasn't about complex methodology. It was about getting a good data source and asking a good question. So the actual technical process was actually really quite simple. Well, I mean, from my relative perspective, I have a PhD in computer science. Maybe that's not a general statement, but we just happened to have this was supposed to be a little side project, and it just turned out to have a bigger impact than even we thought it would have. That just things came together in a good way.
Well, compared with the clinical trial, 2 weeks
Right.
is the amount of time we spend in setting up a conference.
Right. It's the difference, right? If you want to collect the data prospectively, it's a much bigger phenomenon versus are there existing data sources where you won't get as perfect information in the trial, but there's still so much richness you can get from retrospective observational data if you just put it together in a convenient way. And you still want to do the clinical trial work, but even along the way you go, there's a lot of observational information that you can develop much more rapidly. And then, even though we have a speaker, Mark Cullen at Stanford, makes comment that even a clinical trial, it ends up being observational research, right? Because the patients aren't going to adhere exactly to the protocol you intended to. You have to get these follow-up time points in the future time that the protocol can't be super rigid, and you're going to have to use some observational inference based on the patterns of behavior, even in those settings. Our department chair, Bob Harrington, he likes to talk about how he's recognized as a cardiology clinical trial researcher from Duke, even though, his ratio of publications, he publishes one prospective randomized clinical trial, but, 20 other papers, which are the retrospective analysis of the registry data from those randomized controlled trials. And that actually is where a lot of richness comes from. Just because it is so expensive to collect that data prospectively, we also need to find ways to take advantage of all the data that's collected from other sources.
Okay, I don't hear any more questions. If that's the case, I want to thank you again, and we will be in touch for future collaborations, as Betty mentioned, because we're indeed working towards a project that is very relevant to the work you're doing. So just want again to thank you and everybody that is listening in, and hopefully we will be meeting soon.
Very good. Thank you so much for this opportunity. It was great to be here.
Okay. Thank you all.